So today I want to look at three things. First, what is the current standard of care without using the panel? And I have a lot of experience with this, unfortunately. Number two, we want to look at the sensitivity of a negative panel, especially for antivirals, antibiotics, and antifungals. And then we want to look at the potential clinical impact of a negative ME panel. So to begin with, this study, it's a multi-centered international study. We participated in this study and showed a lot, shared a lot of our patients. But the bottom line here is that more than 50% of all CNS infections in the world don't have a diagnosis. So if we have somebody with meningitis or encephalitis anywhere in the world right now, more than half, we don't know what they have. And it's very frustrating for not only the patients, the family, the clinicians taking care of all these patients. In our hospital in Houston, this is a very large study of aseptic meningitis, and this is what happens before the panel. We have 404 adults versus 105 children. And when you see the utilization of the PCRs, for example, for HSV, it's only 39% of the adults get an HSV PCR. Kids, 16%. Norovirus PCR being the most common cause of aseptic meningitis. Only 15% of adults got a PCR. Kids got 74% got tested. VCV, only 1% got tested in both adults and kids. So at the end of the hospital stay, in adults, 86% of them did not have an etiology. This is in Houston, in a very large hospital. In kids, it was 62%. So when you look at the management of those patients are being admitted to the hospital. The majority are being admitted to the hospital. You can see 95 to 100%, a lot of antibiotic use, even acyclovir use, and everybody does well at discharge. So everybody with aseptic meningitis has a good outcome, but they're in the hospital typically for 3 to 4 days, getting IV antibiotics, IV acyclovir, and getting a lot of cranial imaging that's also, in this scenario, useless. Switching to encephalitis, these are the 5 guidelines that have been published. IDSA, the British guideline, the Australian guidelines, International Consortium, and the French guidelines. And all of them recommend that we should be doing HSV PCR testing, VCV PCR testing, and enterovirus PCR testing on our patients. In a recent study of 340 adults with encephalitis in our hospital, this is between 2000 and 2017, you can see that HSV PCR was done in 70% of our patients, enterovirus PCR in 40%, a VCV PCR in 1/4 of the patients, and only 14% of the patients had an NMDA receptor antibody tested. So really, a lot of patients don't get a full workup of their etiologies. So obviously, the problem with this is that the majority of the patients are going to have unknown etiology. In patients less than 65 years of age, 58% of them had unknown etiologies, and 46% had a bad outcome. In the older than 65, 50% had unknowns, and 60% had adverse clinical outcomes. So again, the majority of the patients with encephalitis in our hospitals don't have a diagnosis and have bad outcomes. This is a bad combination. We need to know what they have so we can treat them appropriately. So overall, if you look at meningitis and encephalitis in the United States before 2014, before the BioFire panel was available, you can see that the majority of the patients are going to be on antibiotic therapy, 90% for a median of 4 days, antiviral therapy with acyclovir, 57% for 3 days, and antifungal therapy in 8% of the patients. But the most common etiology of meningitis and encephalitis in the US is enterovirus, around half of them. And you can still see that around 90% of them are getting antibiotic therapy for 3 days. A lot of them are getting acyclovir, 56% for another 3 days that are not helping those patients, and obviously it's a cost and safety issue. Not only they get antibiotics and acyclovir and antifungals, they also get steroids. So steroids overall, around 16% of all patients get steroids. Steroids are really indicated only in pneumococcal meningitis in adults with pneumococcal meningitis. And in this study, out of 26,000 patients, in those that had pneumococcal meningitis, you can see those that got steroids had a lower mortality than those without steroids. But really, this is the only subset of patients with meningitis and encephalitis that should be getting steroids. But obviously, all the others, arboviral, fungal, herpes, enterovirus, they're all getting steroids as well because clinicians don't know what they have when they first come in, so they get placed on steroids empirically. Recently, the Mona Lisa study was published. This is a very large study done in France, and it's the first time that it shows that steroids in Listeria meningitis is associated with a worse outcome, with mortality. So giving steroids for patients with Listeria is bad. So now we have pneumococcal meningitis where it's indicated, and Listeria, another cause of bacterial meningitis where it's not indicated and it should be avoided. So knowing what the patient has is very important, so you can withdraw the steroids if the patient has Listeria and continue it if you have pneumococcal. So clinicians in the ER are always baffled when patients come in with meningitis and their gram stain is negative, and you have this very large differential diagnosis. Could it be herpes? Could it be crypto? Could it be TB? Could it be bacterial? Could it be viral? What to do with the patients? So we actually derived and validated a model to try to figure out a model that identifies patients at very low risk of having something treatable, an urgent treatable cause. So bacterial meningitis, herpetic meningoencephalitis, cryptococcal meningitis, anything that needs to be treated right away. And we found 3 factors associated with an urgent treatable cause. So if you had altered immune status, age greater than 60, HIV, transplant, chemotherapy, recent steroids, abnormal exam, the patient had a GCS less than 15, had a vesicular petechial rash, had a focal neurological deficit, ataxia, or seizures, or had abnormal laboratory findings. So low glucose, a white count in the serum greater than 12,000, and or a protein greater than 100. So those were the 3 factors associated with an urgent treatable cause. If you have none of those factors, none of those 3 factors in our derivation sample, we had 193, there were no urgent treatable etiologies. If you had one of those factors, it was 30%. In the validation cohort, another 567 patients, no risk factors, 0 risk group. And if you had one of those factors, 20% risk factors. And then we validated this with 214 patients from the Netherlands, the Dutch meningitis cohort study, where they had gram stain negative but culture positive. And all the patients were in the high risk group and none in the low risk group. So in a study of 960 patients in 3 different centers, we were able to identify a 0 risk group with 100% sensitivity and negative predictive value. So this is published. It's not part of any guidelines right now, and clinicians are not using it, but to my knowledge, but it's a tool that you can use in the ER to try to figure out who is going to be at really 0 risk of having something that needs to be treated right away. Now we come to the panel. So the panel, as was FDA approved in 2015, is the only multiplex PCR that looks at all the bacterial isolates, several viral targets, and cryptococcus, neoformans, and gattii. This is the study that made it FDA approved. It's 1,560 specimens, and this is a graph that looks at concordant positives, discordant false positives, and false negatives. So initially, you can see that false negative for bacteria was only seen in one, in a group B strep, one patient out of 1,560. So that was 0.06. For viruses, there was false negative in 0.2. Cryptococcus in this study was 0. False positive for bacteria, you see there was some pneumococcal here. So there were 9 out of 1,560, so 0.6%. Viruses was 0.6 and crypto was 0.1. So everything was really low. So very high sensitivity and specificity. In our hospital, we've been doing a study looking at leftover CSFs on patients with meningitis and encephalitis that includes adults and kids. So since June of last year, we enrolled 118 patients. What we noted in this study was that 20% of the patients were getting a second or third or even fourth LP to get more CSF to test for other organisms. So that's definitely something that could be avoided with the panel, because the panel only requires 0.2 cc's and includes all targets. But 1 out of 5 of our patients are still getting repeat LPs. The panel was positive in 41%, so there were 48 positives. And when we compared the panel with the diagnosis in our hospitals, we saw that viruses were detected much better with a panel than at the hospital. Bacteria was also detected better. In crypto, we did have false negatives. Those patients with false negative, a lot of them had positive cryptococcal antigens, but cultures were negative, and the titers on those antigens were low. But this is something that is being reported in the literature as well. So when we looked at the discrepancies between why we're picking up more cases with the panel than at our hospital, we saw that for herpes, we've detected 16 patients. The hospital detected 10. 4 was because they did not run the HSV PCR. So again, depends on the physician, depends on how much CSF you have. Tests are ordered or not. Even though you order it, there's not enough CSF, so it never gets done in some of our patients. So 4 was never done. 2 were negative. One of these patients had a classic HSV encephalitis, had left temporal lobe enhancement, had a negative PCR once, and repeated twice negative at our hospital. And then because they had 2 negative HSV PCRs, they went out and treated for autoimmune encephalitis. So the patient was placed on steroids and IVIG, and all the autoimmune tests came back negative. So the patient never had autoimmune, and the BioFire picked it up months later on stored CSF. So that was really alarming for us. Same with VCV. So there was 10 cases of VCV, and only 4 were detected by our hospital. 4 because it was never done, and again 2 were negative in our hospital, but it was picked up by the panel. In enterovirus, the same thing. We picked up 2 more because the enterovirus PCR was not done. And that was not only part of the problem, but also the around time was different for the different pathogens. So this is current data. The enterovirus had the best median time to diagnosis, 16 hours, but VCV took 26, and HSV took 60 hours to come back. So again, turnaround times is a big problem, because if you don't get the result in time, then you're going to continue antibiotics and antivirals empirically until you get those results. And also, when we looked at the panel that were positive for viruses, they all were there for 5 days. Everybody got antibiotics for 3 days. So again, the same standard of care goes on in our hospital. The majority getting antibiotics for 3 days, waiting for the culture, the majority getting antiviral, acyclovir, and even steroids for a couple days. So when we look at false positive rates, because that was a concern initially with the big study, there were 7 patients that were positive. If you look at the studies, though, this is fairly rare. This is a study by Jennifer Bienbarg in LA. She had 2 cases out of 219, so a false positive rate of 1%. In another study just published recently, just this month, in Hospital Pediatrics, they had 223 patients. You see that they had positive ME panel for bacteria in 8. It was only culture positive in 3. In those 5 where it was negative on the culture was because they had received antibiotic therapy before, and it was consistent with a bacterial meningitis. So they were able to pick up 5 more cases of culture negative bacterial meningitis. And then negative ME panel was seen in 2 that had a positive culture. Those 2 positive cultures, though, was Enterococcus cassiflavus without any pleocytosis and Bacillus non-anthracides. So those were definitely contaminant, and they were considered contaminant by the investigators. So in this study of 223 patients, the negative predictive value for the ME panel was 100%. In this study from Italy, they did the panel on both community and hospital-acquired meningitis. The panel is only intended to be done in community-acquired meningitis. So in this panel, the Staph aureus obviously is not in the panel, so the panel was negative and the cultures were positive. Same with Pseudomonas and Kingella. They're all healthcare-associated meningitis panel, so that shouldn't be used in this scenario. But for all the other community-acquired pathogens, there were no any false negatives on this study or false positives. This is a study that was presented last year, ID Week, from a small public health hospital in Colombia, where we looked at the impact of the film array before and after. So this standard of care, and this with the film array. And what we can see here is that the time from test result to initiation of appropriate therapy was reduced from 195 hours to 2.1 hours. So in this study, the ID doc was called with the results, and they're the ones in charge of changing the antibiotics and adjusting the orders on those patients. So that very quick reduction in time into appropriate therapy. This study is currently being reviewed, hasn't been published. Another very large study done, 705 patients underwent testing. 68% had a clinical suspicion of CNS infection and 59 were receiving empiric therapy. The median time to result of the panel was 1.5 hours. And again here, the false positive rate was 1 out of 705, so 0.14%. It was a strep pneumo that was false positive. And false negatives, there were 0. So again, another very large study showing 100% negative predictive value for the ME panel. In community-acquired meningitis, obviously, there's a pathogen that gets missed, especially in Southeast Asia. If you go to Vietnam, the most common cause of bacterial meningitis is Streptococcus suis. You can see here that out of 617 patients with CNS infection, 147 were strep suis, and only 35 were strep pneumo. So this is much more common than Streptococcus pneumonia. So if you're in Vietnam or in parts of the Southeast Asia where strep suis is a consideration, the panel can be obviously negative for that pathogen because it's not included. So the main question, can we stop antibiotics if the ME panel is negative? So again, the ME panel has almost 100% negative predictive value for the pathogens included in the panel, but can occasionally miss some pathogens. Staph aureus can occasionally cause Staph aureus endocarditis and a community-acquired meningitis, so that could be missed, obviously, because it's not in the panel. E. coli, we've seen patients with E. coli community-acquired meningitis in the setting of disseminated strongyloiditis, so that's another thing that could be missed by the panel, and strep suis in Vietnam. So basically, if it's community-acquired and the patient is really at low risk, it doesn't look like bacterial meningitis. The clinical picture is not consistent with bacterial meningitis, and the panel is negative, I think it's definitely safe to stop antibiotics instead of waiting for the CSF cultures. I know that's against what's being done right now, but the data is so strong that I think if the clinical suspicion is low and the panel is negative, I think it's very good that we could stop antibiotics. So now switching to acyclovir. So with acyclovir, there's HSV meningitis and HSV encephalitis. So for meningitis, it's different from encephalitis. This is a study that we did in Houston, where basically we looked at 60 patients that had herpes meningitis. Almost 2/3 got some sort of antiviral, some IV, different regimens, some orals. 30% didn't get any antivirals at all, and they all did well. So in HSV meningitis, really the data, there's no clinical trials showing that there's a benefit in treating those patients, and a lot of those patients don't get treated, they do well. So it's not really that they're gonna die if you don't treat them with acyclovir. In contrast, HSV encephalitis is a different story. Those patients need urgent therapy. So this is the study done by Hakam Erdem in June 2015, 438 patients with proven herpetic meningoencephalitis, 53% death or disability, so half of them had a bad outcome, and the two risk factors were age and GCS. As age went up, outcomes went up. As GCS went down, outcomes went up. And the only thing that you could do to change that was antiviral therapy. And if you notice here, the antiviral therapy they broke it down into less than 2 days, 2 to 7 days, and more than 7 days. So if the patient got acyclovir within 2 days of symptom onset, you're around 42% had a bad outcome. If you waited 2 to 5 days, it went up to 55, and if it was more than a week, 70% of them had a bad outcome. So a linear kind of progression of bad outcomes if you delay therapy. It's a long wait. 2 days is a lot of time, but unfortunately with herpes, there's misdiagnosis initially, and a lot of our patients, they're not worried about encephalitis initially sometimes, and the diagnosis sometimes get delayed. So if you look at the recommendations, again, the 5 international encephalitis recommendations, they all recommend to repeat the CSF HSV PCR in 3 to 7 days. In our study presented last year at ID Week, only 14% of the 241 patients in our hospital get a repeat LP. So that's something that we need to, it's based on case reports. So case reports have shown that sometimes the PCR can be negative initially and can turn positive if you repeat the LP within 3 to 7 days. That's why the recommendation is there. It's based on few case reports. So can we stop acyclovir if the panel is negative? So I think in aseptic meningitis is definitely appropriate. Panel is negative, I would stop acyclovir. In encephalitis, it's more tricky because they're recommended a repeat LP 3 to 7 days if there's a clinical suspicion of HSV encephalitis because of the case reports. This is based on the sensitivity of the CSF HSV PCRs that have been done before. We're not sure if that's going to change with the panel or not, but the recommendations are out there right now that even if it's negative, we should continue acyclovir and repeat another LP 3 to 7 days before you stop acyclovir. In encephalitis, again, it's very important. If the panel is negative, the next big thing is autoimmune etiologies. So if you look at our study here, idiopathic was 41, viral etiologies 27, right after viruses, autoimmune 21%. So really neck and neck viral etiologies and autoimmune etiologies. So if your panel is negative, you should quickly start thinking of autoimmune etiologies. And this is just a case report that we have showing that. So this is a patient that was transferred from another hospital. She was started on acyclovir empirically because she had encephalitis. They did a PCR in the outside hospital that was negative. So she comes in on acyclovir. We repeat the LP as recommended by guidelines, and it's negative again. So the same day we get the second LP, we're already thinking autoimmune. So we order a pelvic ultrasound. The patient was 29 years old, young, so we were worried about ovarian teratoma. And the ultrasound showed an ovarian mass. So with that, the suspicion really increased that she had anti-NMDA receptor encephalitis. So she continued on the IV steroids. OBGYN was consulted. She underwent a oophorectomy. They removed the tumor, and they started IVIG. And then day 11 or 12, we got the result of the anti-NMDA. So this is a 11-day it took to get the anti-NMDA. So it's very important to quickly start thinking of autoimmune etiologies because they're treatable. The treatment is steroids, IVIG, tumor removal if there's a tumor, plasma exchange, rituximab. Patients do better if the treatment is initiated sooner than later. So it's really important if your test is negative to quickly move to autoimmune etiologies. Meanwhile, you wait for the West Nile serologies that also take a week. And now lastly, for antifungals. So the panel includes cryptococcus. This is one of the first studies looking at the correlation of the BioFire FilmArray with culture. And they did a very nice analysis in this study from patients from Africa where they quantified the cryptococcus. So you can see here, if you had more than 100,000 CFUs of crypto, all those panels were positive. It was between 10,000 and 100,000, there was one negative. If it was between 1,000 and 10,000, they were all positives. 100 to 1,000, there was one negative. Once we start getting low numbers here, 1 to 99, there were some negative. And sterols, there was a lot of negatives. So it clearly correlated with the quantitative culture of cryptococcus. But further studies have looked at the sensitivity of the panel with cryptococcus. This is a study done by Dr. Leisman where she used stored CSF. She had 50 cryptos, and it was only positive in around half of them. But again, when they looked at patients that had a positive culture, there were 12 of the 13 patients that had a positive BioFire. The majority of those that were negative were positive by cryptococcal antigen and not by culture. So again, it's now very well known that the cryptococcal antigen can be positive and both the PCR and the culture can be negative. The PCR correlates better than culture, better with culture than with cryptococcal antigen. And again, a lot of the scoring results that you'll see is because patient was treated with antifungal therapy and the cryptococcal antigen remains positive. It can remain positive for years. And also, some cases could have been iris and not really a true fungal relapse. Furthermore, a negative cryptococcal antigen after fungal treatment does not really correlate with CSF sterility. So if you have patients that have been treated with antifungal therapy for 2 weeks, you repeat the LP, the culture is negative, but the antigen is still positive. So can we stop antifungal therapy if the ME panel is negative for crypto? So I think crypto can be reliably ruled out if both the BioFire panel and a CSF cryptococcal antigen are both negative. So again, those are very quick turnaround tests. The antigen, you get it the same day and as well as the panel. So in one day, if they're both negative, you can, I think, highly stop antifungal therapy if you're just ruling out crypto. But in patients that come in with chronic meningitis and you're thinking, could it be histo, could it be cocci, you gotta put that in the consideration as well, especially if they travel to an endemic area or the patient has AIDS or transplant. Are you worried about histo? Cultures for both of them are unreliable. So in those patients, you definitely want a CSF cocci and a histoantigen as well to rule them out before before stopping antifungal therapy. So again, in those scenarios, you got to always worry about that. Cocci and histo are rare compared to crypto. Crypto is the majority of the fungal meningitis we see, but obviously it happens, and we do see it in Houston occasionally, cocci and histo. And with that, I'm just going to entertain any comments or questions.